General, if you're a low risk surgical candidate, we go for a surgical AVR, whereas if you're a high risk, we go for the less invasive TAVI. But again, that's a decision which cardiology will make. So we'll just move on to kind of our last case now, because I know we're coming towards the 45-minute mark, which was told how long to keep it to. And this one's kind of a bit of a different approach, where it'll just highlight some other things which we've not covered yet. So in this case, you're the F1 on AMU, and you just receive a call from microbiology, and they tell you that a patient, Kevin, who came in yesterday, had staphylococci in both of his blood cultures. They think it's Staph aureus, but the microbiologist can't be sure until tomorrow. What do you do now? Does anyone want to say what your next steps are? So you've just had that call over the phone. So I've had a couple of suggestions from people as well. So the first thing is you don't know anything about this guy. So you want to find out a little bit more about the patient. So why did we actually take these cultures? And you want to find you find out that he was a 56-year-old gentleman who was admitted yesterday with fever, and he's being treated for a sepsis query source. So causes of kind of a Staph aureus bacteremia, which is when they've got Staph aureus in your blood cultures, like we found. So primary, in 20% of cases, we never actually find a cause. But secondary is where they've got infection in a distant site. And some of the important ones to think about are there any kind of skin and soft tissue infections? Are there any lines in this patient which could have got infected? And then you want to think about more kind of the deep-seated infections as well. So is there any bony infections? Is there anything such as discitis, or is there anything like endocarditis? So anyone want to suggest kind of further investigations when someone's got Staph aureus in their blood cultures? I'll give you a second again just to send a couple of through. So some of the investigations, if someone's always got Staph aureus bacteremia, so someone suggested sepsis 6. It's important if someone is septic to always do your sepsis 6. But with your Staph aureus bacteremia, some of the key things you want to do are repeat those blood cultures. You want to make sure it's just not a contaminant first. But then one of the key things which you need to do is to do an echo. Everyone who has Staph aureus bacteremia needs an echo, and that's because we need to rule out that there's any infective endocarditis. And further investigations depend on the clinical picture. If you just give me 1 second, I'm just going to turn my light on just because it's got a bit dark. So the further investigations that you might need depend on what symptoms they're complaining of. So if we go back to that list of where it can come from, if you had any lines in the patient which you thought might be infected, you could send that for a line culture. If you were worried that there was any kind of bony infection or back pain, that's when you'd start thinking about discitis and you'd want to get an MRI spine. But an echo is the one which everyone needs to have who's had a Staph aureus bacteremia. So we go back to our gentleman and you review him, and it turns out that he's actually an IVDU. You have a little look at his hands and you re-examine him and you see that he's got an erythematous non-blanching rash on his palms, and you have a little listen to his heart. You just don't think it sounds normal, but you're not confident about it. So does anyone want to just suggest working diagnosis now? Yeah, so someone straight away, kind of giving it away. We're thinking infective endocarditis. So what is infective endocarditis? So it's infection of kind of your endocardium or the vascular endothelium of the heart. And the infection can mainly occur in kind of a couple of situations. So it can either mainly occur on kind of a damaged valve or a valve which has a problem. in normal valve, but it has to be a particular kind of virulent organism for that to happen, or prosthetic valves. And there's a couple of main culprits, kind of microbiology-wise, of what affect it. So Staph aureus is actually the most common. Strep viridans was historically the most common, and that's the one associated with kind of dental procedures. And then also, if you've just had a prosthetic valve fitted, then that means some coagulase negative staph, such as staph epidermis, are also the most common. But for exam purposes, Staph aureus is the most common, but if they mention dental work, go for strep viridans. And some of your risk factors for developing infective endocarditis, if you've had it previously, if you've got any kind of abnormalities or anything indwelling, then that can be sites for infection to take seat. And again, if you've got deep-seated infections such as discitis, then you can get hematogenous spread of your bacteria from there. And then with IVDUs as well, they're more likely to get infective endocarditis, and it's more likely to affect the right side of their heart in these patients, because obviously they're infecting into their venous system, which will then go back to their right side. And looking at kind of the clinical features of endocarditis, so you can get your systemic features, so they get a fever of over 38 degrees, they can get weight loss, and they can get night sweats. They also get those features of valve destruction, so they can get new or changing murmurs, and then they can also get an onset of new heart failure. And then you also get some of the vasculitis and immunological phenomenon. So we'll just have a little look at the pictures of there. So does anyone want to suggest what the one in the top left is? So having a look at your retina and your fundoscope. So anyone want to type in the box what that one is? Yeah, so these are called Roth spots, and that's looking at kind of these little boat-shaped lesions here. And then moving on to the other one, so your top right, anyone want to suggest which one these are? Yeah, so they're splinter hemorrhages, which you can just see in the nails here. And then bottom left, anyone want to suggest those ones, what we're looking at here? So yeah, I've had a message, Osler's nodes. And with these Osler's nodes, these are going to be quite tender, and they occur kind of their subcutaneous swellings, which you can feel. And then finally in the bottom right, I've clicked it away and given it away, so your Janeway lesions. So these are the kind of erythematous non-blanching macules, which you can see on patients. It's important to note that often seeing these signs are quite rare. So just the absence of these signs doesn't mean that someone has infective endocarditis, but they're more interesting kind of clinical things that you can also look out for, but they're not particularly common that you are going to see them. So don't think that just because a patient doesn't have these, they don't have infective endocarditis, but always keep a lookout for them as well. And the reason why they happen, I don't know the exact kind of pathology around it, but you do get kind of immune complex deposition, which can occur in your vessels, which can cause the splinter hemorrhages and can cause the bleeding with the Roth spots. You can also get deposition of the immune complexes in your joints, which can cause joint pain, and it can also occur in your kidneys. So these patients can also sometimes get a glomerulonephritis, which can develop as well. And like we said, in the management of these patients, so with bloods, you need to get multiple sets of cultures, and that's because we want to try and pick up the causative organism. So you want to get 3 sets of cultures over 24 hours. If any kind of unusual organisms are suspected, or if microbiology recommend it, then you can also do some serological tests. You want to get the ECG to have a little look, see if there's any conduction defects, which can sometimes occur once patients get infective endocarditis. You can get a chest x-ray, which may show any new features of heart failure, and you also want to get an echo to look to see if there's any vegetations or valve abnormalities that you can see. And then looking at the diagnostic criteria, so the way you actually diagnose infective endocarditis is using something called the modified Duke's criteria, and it looks at major and minor criteria. So with the major criteria, this is when you have your positive blood cultures. And you can either have 2 positive blood cultures, which show your typical organisms, so things such as Staph aureus, or you can get consistently positive cultures for organisms which are less common. And then you can also get your evidence of endocardial involvement. So that's things such as on your echo showing vegetations, or if you're kind of hearing those new murmurs, which are confirmed by that echo. Then you've got these minor criteria here. So predisposing heart conditions or IV drug use. If you've got fever over 38, any of those vascular or immunological phenomenon, which we talked about before. And then at the bottom, you've got this microbiological evidence or an echo, which doesn't meet those major criteria. And to diagnose your infective endocarditis, you need to have two major, one major, sorry, that's a bit of a typo there, one major and three minor or five minor. So it's always good to have a little look at that criteria. And then just moving on to the management. So you want to start your antibiotics. So to look what antibiotics to use, you'd always just go on microguide and you take advice from your microbiology. But in general, these patients need a prolonged course of antibiotics, and that's because it's quite a deep-seated infection. So they normally have at least 2 weeks of IV, and then you can switch them down to oral, and you need about 6 weeks in total of it. Surgery can always be indicated if there's kind of severe valvular problems, it's not responding to antibiotics, or there's any aortic abscesses, but that surgery is kind of in the most severe cases. So that kind of covers the end of our 4 cases. I realised, sorry, I was going a little bit quickly just to make sure that I tried to finish in time for us. I hope that was useful and kind of going across those 4 cases in a way where it's stuff which you need to know at an F1 level. Does anybody have any questions about what we've talked about today? Or anything else they want to ask?
Thank you very much, Jacob. I think that was fantastic. So I had a chance to look through the nice guidelines, and I'll post the link in the chat. So it does actually say you should first of all check that the patient is taking the medication, as you rightly said, and it says that you should ensure that the medications are being taken at the optimal tolerated dose. So optimal tolerated dose is the term that they use, which is a little bit, I would say, is a little bit wishy-washy, because some patients only tolerate 1.25 of ramipril, for example. So, but yeah, I've posted the link in the chat. There was a question about post-stenotic dilatation, and I'm not sure whether this is a term that you guys have had in your exams or in your teaching. It's quite an old term, but what I think the simplest way to think of it is that you can have aortic valve pathology and coexisting with aortic pathology or aortic root pathology. So you can have an ascending aortic aneurysm associated with, for example, very commonly, a bicuspid aortic valve. And as a result of that dilatation of the aortic root, you can get aortic regurgitation. And that's the mechanism of that. And bicuspid aortic valves can be stenotic. So you can have some patients have predominantly aortic stenosis. Some patients have predominantly aortic regurgitation. And some patients have a combination of both stenotic and aortic regurgitation. Some patients may have a bicuspid aortic valve by itself, and some patients will have a bicuspid aortic valve associated with aortopathies, so dilated aortas and ascending, an aortic aneurysms. There is a theory that the turbulent blood flow, as it goes through the stenotic valve and aortic stenosis, can result in sort of some mechanical changes to the aorta and resulting in dilatation. But to be honest with you, that's kind of more research level. So I'm not sure if this is something you've had covered in your teaching.
I think they may have been meaning the dilatation in the left ventricle associated with aortic stenosis, just from the increased pressures. Okay,
so that's something different. So what I was talking about is in the aorta, so the aortic dilatation. So if you're saying post stenotic aortic dilatation, that's what that refers to. Now, the left ventricle in aortic stenosis, actually it hypertrophies. That's the general initial response. And that's the same for patients who have hypertrophic cardiomyopathy. and they can have outflow tract obstruction. And similarly for patients who have hypertension with left ventricular hypertrophy. So you get this left ventricular hypertrophy. With time, the left ventricle can start to fail, and you can get dilatation of the left ventricle. And that's more of a late stage in aortic stenosis. You don't tend to see that in aortic stenosis. With aortic regurgitation and mitral regurgitation, that's different, because with those conditions, you get a volume overload of the left ventricle. So the left ventricle has just got too much volume, either due to aortic regurgitation or patients of severe mitral regurgitation as well. That volume overload results in dilatation of the left ventricle. And again, that's also a late feature, and that's in fact a sign in terms of, it's a late feature of significant valve regurgitation. So it's actually a sign that the patient will need surgery in the absence of symptoms.
There was another question from Sally as well, actually, just asking if, just to clarify, that anyone who has a Staph aureus bacteremia gets an echo.
So
that's a good question. Yeah, so go on, Jacob, go for it.
Oh yeah, so just from kind of a microbiology teaching which we've had with Insure, if it comes up as like, if the lab say they think it's a skin contaminant, and then necessarily you might not need to do it unless it comes up as a second one. But in general, microbiology recommend that everyone with Insure anyway gets an echo who's had a Staph aureus bacteremia. I'm not sure if it differs trust to trust at all, or.
So I don't know if it does differ from trust to trust, but I think other trusts don't have that policy that blanket everybody with Staph aureus gets an echo. I think the best thing to do is to get your Duke's criteria and score the patient, in terms of the minor. We're talking about minor criteria here because often they won't. The major criteria is blood culture, that you've got one, and then the second one will be the echo. So you have to look at your minor criteria and see whether or not the patient is scoring. So if they've got other features, like they've got a predisposition, if they've got a fever, if they've got evidence of these changes, you can see here rough spots and ostenodes, immunological phenomenon, if they've got any vascular phenomenon, then yes, I would do an echo in such a patient. But in fact, there's one other thing that's not quite mentioned here. Before you even get to this, there are a group of patients when you evaluate them, you can actually rule out endocarditis and not necessarily investigate them further. And these are the patients who have another clear cause. So you have other clear cause of the infection, number one. And number two, once you've treated them with antibiotics, within 4 days, the inflammatory markers are well controlled. If you find that after 4 days treatment, the inflammatory markers start to rise again, or patients who've had recurrent bacteremias, then you definitely need to do an echo, transthoracic first line, but a low threshold for then going for a transesophageal echo to rule it out.
Thank you very much. I just want to ask one question as well. You covered, I think, the main kind of cardiology topics we come across in exams. Are there any other topics you'd recommend people looking at before their exams with regards to cardiology?
So I didn't go to Manchester, so I don't know your curriculum. So I was just sent a list of ones which hadn't been taught already. Obviously, you need to know kind of your heart failure off the top of your head as well. You need to know all about your ACS treatment. That's always going to come up. Other than that, just making sure you look at your curriculum. But I think, yeah, ACS, atrial fibrillation, heart failure, hypertension, and then atrial fibrillation, they're kind of your big ones which are always going to come up in exams. So yeah, I think they're kind of your top ones, but again, I don't want to tell you wrong what's different on your curriculum.
Thank you very much. That was a great talk. I don't think we've got any more questions, so I think we can stop there unless there's anything else you want to mention.
No, and then that's just my email again. So if anyone has any questions which they think of or want to email afterwards, or just any questions about like F1 in general, or you want to ask anything about any other